alone. We will be moderated by Dr. Fahad, one of our incredible doctor in Universitas Muhammadiyah Yogyakarta. Before the lecture starts, I would like to convey the CV of our today's moderator. Dr. Fahad was born in Jeddah, Saudi Arabia, October 21, 1994. Went to kindergarten Muassasa Al-Khairiyah, primary school International Indonesian School of Jeddah, junior high school International Indonesian School of Jeddah, Madrasah Aliyah Pondok Pesantren Sunan Pandanaran, and Faculty of Medicine, Universitas Muhammadiyah Yogyakarta. Organizational experience, coordinator of public relations of National Seminar, initiation and deputy head of Internal Volunteer Doctors, Yogyakarta, general chairperson of Volunteer Doctors, Yogyakarta. Other events, summer medical student exchange to Poland, August 2016. Liaison officer of foreign professor in Universitas Muhammadiyah Yogyakarta, volunteer of flood disaster in Gunung Kidul, Yogyakarta, coordinator of transportation Pentaloka Nasional Adinkes in Yogyakarta, national volunteering with Jajan Pahala Community in Ciwidey, Bandung, awardee LPDP Program Magister. Dr. Fahad, the time is yours.
Can you hear my voice? I want to make sure that my voice is already heard by everyone. Is that clear? Okay, I think. Is that clear enough, my voice?
Yes, I can hear.
Okay. Okay, good morning, ladies and gentlemen. Welcome to the lecture session. My name is Fahad, and I'm one of the alumni of medical studies in Universitas Muhammadiyah Yogyakarta as well. And I will be serving as your moderator today. Okay, firstly, I feel so sorry to say to everyone participants, ITMSS still held online, I think. So wish pandemic is over, but as you can see, until now, there are many cases around the world. So beside Indonesia, especially Yogyakarta, is a place where you can be skipped, yeah, because its beauty and authenticity. Okay, you'll be hearing presentations after this from Dr. Nur Rahmi Ananda, spesialis penyakit dalam, KP Finasim, on this time very timely subject. But before we get started, I wanted to take a few minutes of your time to read her curriculum vitae. So is there any curriculum vitae there to kami read? Or I have to read this one by my. Okay. Okay, this is the gorgeous Dr. Nur Rahmi Ananda. She's an internist pulmonologist. His education start from as a medical students in Universitas Gadjah Mada, one of the best university in Indonesia, in 2006. And in 2014, she already finished to continue her study to internist in UGM as well. And then 2022, she already finished her study in subspecialist in pulmonology. So basically, she is an internist, but she have like a kind of a subspecialist. So it's more like consultant in Indonesia, we say it, in pulmonologist. And then next. And she has a very has so many work experience as an instructor in university in Universitas Islam Indonesia, and she was a doctor also in Halmahera Barat. It's kind of in very very east of Indonesia. It's called Maluku. So she was there as a doctor, and then also she work right now until now as a pulmonologist, and then divisions of pulmonologists as well in UGM and RSUP Sarjito. Maybe you already know about that hospital in Yogyakarta. And also she has so many organization experience from as a secretary. I think most of her organization experience as a secretary, in tuberculosis in RSUP Sarjito, and until now she is as a secretary team viral airborne in Sarjito, and also second secretary as community of internists in Yogyakarta. That's all from for her. So let's welcome to Miss or Dr. Nur Rahmi Ananda SPPD KP Finasim, who will be speaking to us on pandemic COVID-19 as tuberculosis. Time is yours.
Okay, good morning to all. Thank you, Dr. Fahad, for the nice introduction. How are you today? Maybe some of you is still in the early morning, yeah? Yeah, have you already have coffee or yeah? Yeah, first I would thanks to the committee to invite me in this nice lecture. And now I would share to okay. Have you seen my slide?
Yeah.
Yeah, okay. Yeah, in this nice morning, I would share about tuberculosis, and it's related in the COVID pandemic. Maybe some of you or maybe all of you have already known the tuberculosis. It is one of the most ancient disease that still we have a lot of burden in this world, yeah, and especially in Indonesia. And this morning, I would like to talk about the epidemiology and also the definition and pathogenesis and clinical manifestation, pulmonary and extrapulmonary, and also how to manage and prevention. As I mentioned before, that tuberculosis is an ancient disease, and maybe before in the old year we already know the tuberculosis, and now this is surprisingly still the top infectious disease killer in this world. About 1.7 million people died from TB in 2016, and also 10.4 million people fell ill from TB. And each day, 4,700 people lost their life and fall ill because of TB. And this is the estimated TB incidence rate in 2019. You can see your country here. And we, as in Indonesia, we still have a very high incidence. It's still above 300 per 100,000 population. And we know that the most three country with estimated TB cases, the highest in this world. First is India and China and Indonesia. And also we have a burden in MDR or drug resistance TB in Soviet country. They have the most percentage of new DR or drug resistance TB. And this is a country with the high burden TB, yeah, and Indonesia, India, Kenya, and almost all the African country, they have burden both in TB, drug sensitive, drug resistance, and also HIV TB. And about how about the effect of the pandemic to the TB, we can see from these charts that because of the pandemic, the estimated death, the estimated death from the tuberculosis is increased. We know that all of the world have mentioned that we will eliminate TB infection by 2060. And Indonesia, we declare we will eliminate TB tuberculosis in 2030. But what happened after the pandemic, from year to year, we have to reduce the death from tuberculosis, but after the pandemic, we show that the graph is increased because in 2 years in the pandemic, mostly people have a reluctant or have a barrier to go to the hospital because they're scared of COVID. And after the pandemic is over, they came mostly in the severe condition. So the notification of TB decreased and estimated death is increased because of the pandemic. And we all know that from Global Tuberculosis Report 2020, we have to reduce the target to reduce the TB incidence all over the world is about 20% reduction, and what we achieve is still in 9%. And also from the target at 35% reduction of TB death, we only achieve 14%. So there's a lot of work to TB elimination. And what about us in Indonesia? We still have 845,000 estimated TB cases that spread all of over the Indonesia, with only 43% of treatment coverage. Dr. Fahad mentioned before that I have already be the doctor in the North Maluku. If you see, this is the map of Indonesia. We are in Yogyakarta is here and North Maluku is here. From the east of Indonesia, there is a lot of TB incidents, but because the transportation, because the lack of technology support there, so we can the TB incidence is still high here, but our government is still working, and all they have to for the worst case they have to deliver the patient to the Jawa, yeah. And already we have 83% of success rate from TB drug sensitive treatment. But in drug resistance TB treatment, the success rate is quite low, still in 47%. And also we have estimated 33,000 TB cases in children, and also 8,000 with HIV cases. And still, the TB-related death is still high. So what is tuberculosis? Tuberculosis is an infectious disease caused by the Bacillus Mycobacterium tuberculosis. And tuberculosis usually affects the lung, but it can also affect any part of the body. And this is the characteristic of Mycobacterium tuberculosis. Yeah, is the rod shape in 0.2 till half in diameter, and this is acid colic present, so it's acid fast bacilli, so the color is red. Resist the colorization with acid and alcohol. This bacteria is aerobic and non-motile, and it multiplies slowly, and it can remain dormant for decades. Besides the Mycobacterium tuberculosis, we also know that there is some species of Mycobacterium other than tuberculosis. It also causes a disease, but it's called Mycobacterium other than tuberculosis, or NTM, non-tuberculous mycobacteria. It includes Mycobacterium avium intracellulare, kansasi, scrofuloseum, marinum, ulceraceae, and fortuitum. Actually, for the MOTT or NTM, the surveillance is not good as the tuberculosis. And how is tuberculosis transmitted? The bacteria will transmit it from people that have a disease. Usually the lung disease, they have a lung cavity, and the TB bacteria become lighter in weight due to water loss. The size of bacteria after water loss will be several microns, so it will be spread by sneezing or coughing, and the droplet nuclei of TB bacteria in several micron in size when the healthy person next to the ill person, they can inhale the bacteria, and the bacteria can enter the alveoli. And what factors that determine the probability of MTB transmission? First is susceptibility. The immune status of the exposed individual is very, very important factors for the transmission. And the second is infectiousness. Of course, the number of bacilli that expels to the air, huge number of bacilli will give the high probability to the MTB to transmit. And also the environment and exposure. More frequent, more duration of exposure will increase the probability of MTB transmission. And what the risk factor of developing TB disease? Now the strongest known risk factor is HIV infection. And also there's other risk factor include the weak immune systems. First, for the children younger than 5 years of age. And the second, persons who are receiving immunosuppressive therapy, and also persons with silicosis, diabetes, chronic renal failure, leukemia, lymphoma, or the other cancer. And persons who have had gastrectomy and jejunal bypass, persons who have weight less than 90% or the worst nutritional status, also smoker and drug abuse, and also alcoholic. And this is the 5 attributable risks for TB in the top 3 countries with TB in Indonesia, the first risk of TB is people with undernourishment, and also in China and India. And the second attributable risk for TB in Indonesia is smoking. A lot of people still smoke in Indonesia, and also diabetes. And how people get infected with TB, as I mentioned before, that the droplets and the bacilli from the ill patient will spread, and when the contact or the healthy person next to the ill person, they will inhale the bacteria, and the bacteria will enter the alveoli. What happened in the alveoli? We already know that we have two types of immunity. First is innate immunity. A lot of cells in innate immunity, first macrophages, NKT cell, neutrophil, they will work to clearance the infection. Actually, 50% or more exposed person have no immunodiagnostic evidence of TB. So it will be clearance by innate immunity. But if the innate immunity fail to clearance all the bacilli, they will ask, or they will activate adaptive immunity that mostly T cell will work in this adaptive immunity. T cell will come to the infected area, and they release a lot of cytokines, including interferon gamma. That the interferon gamma, we can see the level of interferon gamma from the blood. Yeah, if interferon gamma is released, from the T cell, we can conclude that the person is already infected with TB. We also we know as IGRA, IGRA, the examination called IGRA, immunoglobulin release assay, interferon gamma release assay. And what happened after adaptive immunity is activated? Some people will have clearance. So the IGRA is positive, the tuberculin still skin testing will positive, but the patients did not have the disease or will not sick. Some other people will be in the latent disease. So the adaptive immunity is still work to eliminate the bacilli, but the person that have been infected is not ill also, and and around 5% people will clinically detectable active disease. There are three distinct stages hypothesized when somebody get TB infection. First, the one is war of attrition. It very depend on the immunity. If there's no immunity, the tuberculosis will be disseminated. The person will be sick, and maybe they have severely ill. And when the immunity is strong, the immune cell will have or will form the granuloma. The granuloma consists of the viable bacilli and also macrophages, and also the T cell, and they will keep the bacteria inside the granuloma. Yeah, and when the granulomas form, it contains, and maybe the bacteria inside the granuloma will kill. Yeah, but they can still be viable and wait until the immunity is weak, so they can replicate and they can be infectious and make the person sick. Yeah. They can multiply and cause obstructive lipid pneumonia. The, when in this stage, person will have a sign of pneumonia, and you can see the lesion in the lung. Yeah. And from the CT scan or from the radiographic examination, you can see the sign, 3-in-bud sign, or we can see the obstructive bronchial, yeah, and also caseous pneumonia. But actually, 95% of this obstructive lipid pneumonia will have a resolution, and there is four possibility. First is there's no spread. The bacilli is still on the granulome. There's a lesion, but they have a resolution, so we can just see the fibrocaseous TB. Yeah. But also they can infectious as they make a cavity with paucibacillary cavity, or they can when the bacilli is grow more rapidly, they can be the major cavity with the bacteria along the cavity. Yeah. So when the people is cough, the bacteria could spout out, and then the sputum is positive with mycobacteria. Yeah. So in TB, we have primary, acute or acute caseating, and subdrive chronic fibrosing, and post-primary granuloma. And as I mentioned before, that in TB infection, people that get infected with TB, they can be active disease or latent disease. The latent infection is where the TB people get infected, but the immune system is still controlling the bacteria. So in latent infection, there is no sign of infection. Approximately 1/3 or a quarter to 1/3 of population in this world have latent TB infection. And latent TB infection, when the immunity is decreased, they will have active disease. Yeah, you can see the picture here. When the latent infection is happen, one bacilli, but they can control by the immune system. So the bacilli is kept on the granuloma and not spread out. But in active disease, the bacterial load is high. They have multiply and then maybe spread out to the lung or the other part of the body. Yeah, the patient is have the sign of infection. We know there is 4 spectrum of TB disease. First, when infection is eliminated with innate immune response, when the people have a good quality macrophage, the macrophage is eliminate the bacilli clearly, so there is no sign of infection. When we do the tuberculosis tuberculin skin testing, the result will be negative. The IGRA will be negative. Interferon gamma release assay, IGRA. and the cultural negative, sputum smear also negative. These people is not infectious, although they have infection, but the immune system have success to eliminate clearly. And what happened in the second spectrum, infection eliminated with acquired immune response. So there is mark, yeah, the TST examination will be positive, the IGRA will be positive, but there is no symptoms, and there's no infectious, and the sputum smear is negative. These people do not need treatment. And what we see in the next spectrum, the people can be as latent TB infection when there is a granulome with still viable bacilli. The TST will positive, IGRA will positive, but the people's not infectious, there's no symptom. The people that have latent infection is healthy, yeah, and some people with latent infection with the risk of active TB will get the preventive TB therapy. And also we know there's a spectrum of subclinical TB disease when the bacterial load is not as high as the active TB disease. There's some bacteria outside the granulome. So the symptoms is mild or maybe no symptom at all. But from the chest X-ray, we found there's a lesion, active lesion. And when we do the smear or the culture, they will give the positive result. And this person, although there are no active or there are no symptoms, or the symptoms is very mild, they still have to treat with multi-drug therapy. And the last spectrum is the active TB disease. Patients that usually came to the clinic, they usually have symptoms, cough more than 2 weeks, and or fever or weight loss, yeah. And from the chest X-ray, usually we see a lot of cavity or infiltrate. And as I mentioned before, that almost 85% of all TB cases is pulmonary TB, but we have extra pulmonary side too. TB can infect the meaning the central nervous system or the lymphatic system, or they can infect the pleura and also bones and joint and genital urinary system. And how TB can spread from pulmonary to the other organs of the body. When aerosol droplet containing bacilli enter the body or the alveoli, they will surrounded by the immune cells and form granuloma. And when the immune cells is decreasing, the immune system is weakened, the bacilli can go outside the granulome and enter the bloodstream and also the lymphatic system, and they spread and they can infect more give infection in the lymph node or in the blood or the central nervous system, yeah, and so on. So the people will come with extrapulmonary symptoms. And we also know that there is drug sensitive and also drug resistance TB. How tuberculosis can be or can have a drug resistance. There are two pathways leading to drug resistance. First, the acquired drug resistance, and the second is primary drug resistance. First, from the acquired drug resistance, there is an exposure to drug susceptible TB, and when the people get infections with drug susceptible TB, they have active drug susceptible TB, and they will have exposure to anti-TB drugs. Yeah, so when they get exposure of anti-TB drugs, the bacilli, some of them killed, some other will make the genetic or the gene modification to drug resistance. But we also have a primary drug resistance. This is the people that the exposure that is already drug resistance TB. So it's called primary drug resistance TB. Yeah. In the natural way, there is resistance mutation frequency in Mycobacterium tuberculosis. In natural, there is a possibility of resistant mutation in isoniazid, one of the TB drug therapy, in one in 1 in a million, yeah. And also for the rifampicin resistance is only 1 in 100 million. So the natural way they get the natural mutations is actually very rare. But when they get the exposure of anti-TB drugs, they will increase the frequency. And what about we have some definition of drug resistance. We have monoresistance when the bacteria is resistant to one first-line anti-TB drug only. And polyresistance is when the bacteria resistance to more than one first-line anti-TB drugs other than both isoniazid and rifampicin. And we also have a definition of Mgr multi-drug resistance. There is a resistance to at least both isoniazid and rifampicin. And also rifampicin resistance, if there is a resistance to rifampicin detected using phenotypic and genotypic methods with or without resistance to other TB drugs. And rifampicin resistance disease on its own requires similar clinical management as Mgr TB. Why? Because rifampicin is one of the drugs that have a very good bactericid, and rifampicin is very good in preventing the resistance of the other drug. So when there is a rifampicin resistance, we do the clinical management as multi-drug resistance. And we have pre-XDR TB when TB caused by MTB strains that fulfill the definitions of multi-drug resistance. So the bacteria is resistant to isoniazid and rifampicin, both, and which are also resistant to any fluoroquinolone. XDR TB is when the resistance of both isoniazid and rifampicin resistance, and also its resistance to any fluoroquinolone and at least one additional group A. There is a grouping of therapy for the drug resistance cases, and the group A is levofloxacin or fluoroquinolone bedaquiline, and linezolid. So when there is bacteria that resistance to isoniazid, rifampicin, fluoroquinolone, and bedaquiline or linezolid, we call it XDR-TB. And how the diagnostic approach? The diagnostic approach is according to the clinical manifestation. This can be pulmonary or extrapulmonary TB. And the gold standard is we find mycobacterial tuberculosis in body samples. It can be from sputum, from the pus, from the histological sampling, and so on. And how we can detect the Mycobacterium tuberculosis? There is a three-way. First is from the smear, the acid-fast bacilli smear. We can collect the sputum, and the sputum will get smear, and we see the AFB from in the microscope. And also there is a genotypic diagnostic with GenExpert, which can also detect the rifampicin resistance. And the last is culture. And what the typical symptoms of tuberculosis, active disease, we see that cough lasts for 2 or more weeks, can be chest pain or pain with breathing or coughing, like pleuritic pain, and loss of appetite, chills, fever, unintentional weight loss, fatigue, night sweat, and also coughing up blood. And from the extrapulmonary TB, we can see the sign of pleural effusion and maybe lymph node enlargement, and also ascites, malabsorption, or like a mess, but it's actually TB, and skin ulceration, amenorrhea, or abscess in bones, or loss of consciousness in CNS TB. These some examples of extrapulmonary TB. Pleuritis TB is 20% of TB extrapulmonary case. The pathogenesis is subpleural focus structure, and usually the fluid or the effusion is unilateral, and it can be empyema, or there is empyema, there's infection, and the clinical manifestation is cough, chest pain, and fever. What will we do if we have the pleuritis TB? We usually do the thoracocentesis. We draw the fluid from the thoracic, from the pleural space, and we examine the fluid in the laboratory. And this is one sign of lymphadenitis TB. The lymphadenitis TB is the most frequent sign of extrapulmonary TB case. There is around 30 or 40%. The location is dominantly in cervical, supraclavicle, axilla, and thorax. It can be unilateral, can be multiple, and usually it's indolent. And this may happen without systemic manifestation, just the lymph node enlargement, and it can be a necrosis or abscess or ulceration or fistulation or scrofulae. Can be like this, can be like this, and when we do the biopsy, there is a caseating necrosis inside the histology finding, yeah. And in the CNS TB, this Actually, this is a rare case, but in the country with high burden TB, we see this patient maybe once or twice in a month in the referral hospital, like my hospital. This is a sample of CNS TB. Yeah, the symptoms is cephalgia 2 to 8 weeks with meningeal sign, and people that infected with CNS TB will give symptom of malaise, anorexia, fatigue, fever, myalgia. Yeah, it's very it's more frequent in high burden country. What will we do if we see the patient with suspicion of CNS TB? We can do the lumbar puncture. If there is no contraindication, we will do the lumbar puncture. We draw the LCS and give and check the LCS for the TB. We can do the gene expert and also culture. And this is a example of abdominal TB. Actually, abdominal TB is 11% of all EP extrapulmonary TB case. The clinical manifestation is a very wide range, yes. Some patients will have a severe abdominal pain or unexplained weight loss or constipation or diarrhea or hematostasia, or they have abdominal mass, but after they get the biopsy, surprisingly the mass is TB granulome, yeah, or the TB necrosis. And also they can came with lymphadenopathy and ascites. The typical sign of ascites in TB is full of fibrin, yeah, and septum. We call it complex ascites. And we can see the abdominal TB, or we can diagnose abdominal TB from the CT scan. If there is a peritoneal thickening and also ascites with septation and omental caking, and also lymph node enlargement in the abdomen. Yeah, some patient will have the pericardial TB. Yeah, we also have some patients with this pericardial TB. Usually, young patients came with tamponade and also fever. And after we draw the pericardial, we do the pericardial synthesis and we check the pericardial effusion. Surprisingly, the TB is positive. So we usually give the multi-drug treatment, and the patients will cure after 9 months. This is example of bone and joint TB. Yeah, 10% of extrapulmonary TB case we can see, we call it gibbous, and we can see the destruction of the vertebrae, and the symptoms are not specific. It can be sensoric or motoric involvement, depends on which part of the vertebrae that affected, and this is need biopsy to confirm diagnosis. And what we have for TB testing, from the laboratory testing for TB, currently we have current methodologies for tuberculosis detection with some modalities. First is direct microscopy, the second is culture method, and the third is rapid molecular tools with active tuberculosis detection. For the example is gene expert with rifampicin resistance with a real-time PCR assay. And we have also GeneXpert Ultra. They have more sensitive for diagnosing TB. And we also have LPA, loop isothermal amplification. And also we already have lateral flow urine arabinomannan assay, but only for HIV, severe HIV patients. And the current methodologies for drug resistance detection, we have two types. The first is phenotypic-based drug susceptibility testing. And also we have rapid molecular tools for detection of drug resistance with LPA, line probe assay, or GeneXpert. And also we have the whole genome sequencing for diagnosing the resistance. Yeah. And how about the benefit and disadvantage of each laboratory diagnostic approach? First, from the direct microscopy, also we know as AFB smear or acid-fast bacilli smear. The mycobacteria are distinguished from other microorganisms by thick lipid-containing cell walls or by acid-containing reagents. If there is mycobacteria, the AFB smear will be positive. And the advantages, this is a very simple and inexpensive, almost primary healthcare in Indonesia have this, and it's quickly detecting infectious cases of pulmonary TB. So they can diagnose TB easily just from the sample sputum and microscope, a simple microscope. And the disadvantages is relatively insensitive because we need at least 5,000 bacilli per millimeter of sputum are required for direct microscopy to be positive. So when the bacilli is less than 5,000 bacilli in 1 millimeter sputum, the result of AFB smear will be negative. So it gives a negative, a false negative result. Yeah. And smear sensitivity is further reduced in patients with extrapulmonary TB, those with HIV co-infection, and those with disease due to non-tuberculous mycobacteria. And also, the AFB smear have limitations. Microscopy for acid bacilli cannot distinguish Mycobacterium tuberculosis from non-tuberculosis mycobacteria, nor viable from non-viable organism. And also they cannot distinguish between drug resistance and drug susceptible TB. How about the culture? The culture of a specimen or the culture for mycobacteria, it will give advantages as a definitive diagnosis of TB and significantly increases the number of cases found, often by 30 to 60%, and can detect cases earlier. Yeah, because 1 to 10 bacilli in the sputum we can detect with culture. Yeah. In AFB smear, when the bacteria is less than 5,000, we cannot, or it will be give us a negative result. Yeah. But and the other advantages from culture is culture also provides the necessary isolates for a conventional drug sensitivity tests. Yeah. From the culture, we can cultivate the bacteria, and also we can do the conventional drug sensitivity testing. But the disadvantages is culture is much more complex and expensive, and not all the laboratory can do this. because it needs a specific requirement and specimen processing growth of the organism and needs skilled laboratory technician. And the culture is also have limitation. Specimens have to be decontaminated prior to being cultured to prevent overgrowth by other microorganisms. So all the contamination methods are to some extent also harmful to mycobacteria, and the culture is therefore not 100% sensitive. So it can give the negative, false negative result also. But the positive culture have to be identified to differentiate Mycobacterium tuberculosis from non-tuberculous mycobacteria. And also the confirmation is usually done by combining biological characteristic of the culture growth and selected molecular or biochemical tests. Yeah. And we have also drug susceptibility testing. The advantages is DST provides a definitive diagnosis of drug resistance TB, but from the phenotypic methods involve culturing of Mycobacterium tuberculosis, so it will need 8 weeks to culture the Mycobacterium tuberculosis. And we also know genotypic methods target specific molecular mutation with rapid diagnostic. Yeah. And we also know that there is 2 types of drug sensitivity testing. First, drug sensitivity testing for the first line. First line DST is most accurate for rifampicin and isoniazid, and less reliable and reproducible for streptomycin, ethambutol, and pyrazinamide. And rapid DST is essential for identifying patients at risk of Mgr Tb as the first priority. Once MDR has been confirmed, additional first and second line drug susceptibility results should be obtained following WHO recommendation. The second line DST is more complex and expensive because we need we test for the second line drug like fluoroquinolone, ethionamide, prothionamide, cycloserine. Have you hear this drug? This is a drug for MDR or drug resistance TB. And how we use the algorithm for use conventional microscopy. In the district area, we have all the simple microscope, and when there is a negative or no result, we can send the sputum for the culture, both solid or liquid culture. And if is it positive, we can do the drug susceptibility testing, the first line. And if there is MDR, we can do the drug susceptibility testing for a second line drug. Yeah. And this is the same. And how about the radiological examination for TB? We can have chest X-ray, CT scan, or PET scan, or MRI. The importance are varied over time. This is sensitive but not specific. And the chest X-ray is a key diagnostic test and for early TB detection. And WHO have recommended the radiological or chest X-ray for screening, for TB screening, because it may provide data in early TB. Yeah. We know but when we see the X-ray, we must differentiate whether this is the primary or active or inactive lesion. how we recognize. This is the example of the primary TB imaging pattern. There's only hilar lymphadenopathy, yeah, with no sign of other abnormality. There is no infiltrate, there is no cavitary, yeah, but we only have this hilar lymphadenopathy. And this is the radiological examination for a post-primary TB pattern. Usually we see the cavity, the multiple cavitary with the with the thick wall, and also there is an infiltrate. Yeah. And also we know this is the miliary TB pattern. This is pretty characteristic. It's quite characteristic of the miliary TB pattern. We saw there is dots, yeah, that miliary. And this is the symbol of the pleural effusion because of TB. We can see there is a fluid here, and there is also the fibrosis and calcification. And what about extrapulmonary TB involvement? We can see from a PET CT, there is a high uptake of PET, yeah. So we see there is a positive in lymph node, in axillary lymph node, and also in abdominal lymph node. So it can be differential diagnosis with cancer. And this is from the CT. We can see the granulome here. And it's also TB. There's bone destruction from the MRI result. And how we differentiate the active from the inactive TB. In active TB, we can see the 3-in-bud sign or clustered nodules or the centrilobular sign and miliary nodule, thick-walled cavities, consolidation, pleural effusion, enlargement lymph node. And when there's inactive, we just see the fibrotic bands or reticulonodular scarring or calcified lymph node, or thin walls cavities and bronchiectasis. Yeah. So when we see one of these sign, we can conclude as active TB. If we only see one of these sign, it may be it's inactive. So this is the example of healed lesion for from TB. There's a fibrosis, yeah, and also calcification, and this also cavities, but thin wall, and also reticulonodular with fibrosis. This is more severe TB sequelae. There's a lot of cavities, but thin wall, and the cavities is already fulfilled with, usually there is jamur, there is infection here, aspergillosis inspection after TB. And this is one sample of destroyed lung because of TB. Yeah. So when the TB, after the bacilli is clearance with therapy, patients can still have these sequelae. And how to take samples, we can do sputum induction or bronchoalveolar lavage or laparoscopy or ultrasound guided pleural aspiration, or maybe FETs. Yeah. And this is a TB diagnosis algorithm. If we have the TB presumptive, we can do rapid molecular testing with gene expert. And from the gene expert, we can diagnose patients with TB with drug resistance or drug susceptible. If there is a drug resistance, we can treat with drug resistance, and when it's susceptible TB, we can treat with drug susceptible TB. And what about the treatment? Or Dr. Fahad, do I still have time?
Yes, you still have your time, doctor.
Yeah. And for the treatment, what time I still have how many minutes? I still have 30 minutes. Okay.
15. Yes.
Okay. Okay. And for the treatment of the TB, there are three main objectives of TB treatment. First is to reduce mortality and morbidity for affected patients and avoid the risk of further transmission. To achieve this objective, drugs with bactericidal activity are needed for their ability to kill the rapidly dividing metabolically active bacilli found in the cavities and sputum of patients with microscopy smear-positive PTB. And the bactericidal drugs include isoniazid, rifampicin, fluoroquinolones, levofloxacin, moxifloxacin, and also a second-line injectable agent. Also bedaquiline, linezolide, telamanid, and meropenem. And the second objective is to avoid the selection of drug-resistant mutant bacilli. To achieve this objective, it is necessary to administer drug combinations, at least of 4 new drugs. And the third objective is to avoid relapse. To avoid relapse, drugs with sterilizing activity are needed for their ability to kill persisting, dormant, and intermittently active bacilli responsible for relapse and rapid sterilization. We have two principles of treatment. First, the combination of drug, at least 4, to avoid selection pressure, and the need for prolonged treatment in order to sterilize all infectious sites and thus cure the patients and prevent relapse. We have a lot of anti-TB drugs right now with we categorized that have some prevention of resistance according to bactericidal activity or sterilizing activity, and we know that rifampicin is very have high activity for prevention of resistance and also bactericidal activity, and also have sterilizing activity with low toxicity. So that's why rifampicin is we call the core drug for tuberculosis. And also we have isoniazid, ethambutol, and pyrazinamide. And how many times or minimal we have drug resistance sensitive TB, minimal 6-month therapy, 2 months intensive phase with rifampicin, isoniazid, pyrazinamide, and ethambutol, and continued with 4 months of rifampicin and INH. But now the WHO is introduced the more not no longer, only 4 months. Yeah. And what about the drug resistance TB? We treat the patients for 9 to 12 months with short-term regimen. And if there is complication or the patient cannot receive the short-term regimen, they will have the longer regimen or individual regimen with 18 to 24 months. There are three groups of the Rtb drugs. First is group A, consists of levofloxacin or moxifloxacin, bedaquiline, and linezolid. Group B is clofazimine and cycloserine, and the other group C is add to complete the regimen ethambutol, delamanid, pyrazinamide, amikacin, ethionamide, or prothionamide. How to make the regimen? Usually we include all the group A and include all the group B. So we have 5 drugs. Remember that the treatment is minimal 4 drugs. Okay, this is the short-term regimen. 4 to 6 months with bedaquiline, levofloxacin, clofazimine, INH, pyrazinamide, ethambutol, and ethionamide. And 5 months with levofloxacin, clofazimine, pyrazinamide, and ethambutol. You can imagine how the patients will suffer. They suffer from the disease, and also they suffer because a lot of drugs that have to they have to have a lot of drugs daily. And we still try to actually for the drug resistance, we still have to do the research more to find the minimum therapy that because more longer the therapy, more longer the patient need to comply, it can be difficult for the patient. Yeah, it can be until 2 years. Imagine a lot of drugs that have to take daily in 2 years. That's why the treatment success is still low. Yeah. And the tuberculosis, now they can treat and they can prevent it. The tuberculosis preventive treatment is give to the latent tuberculosis infection. Yeah. When we try to eliminate tuberculosis in 2050, we just not if we only do the treat active TB, we will not meet the goals. But this is a sample. When we also treat the latent TB, maybe we can reach the goal by the time that we will eliminate TB. Yeah. So now the WHO is recommended to give preventive therapy for latent tuberculosis. Yeah. As you know that latent tuberculosis, the patient is not sick, so probably they won't came to the health facility. So how we find the people with latent tuberculosis? We have to do active TB case finding. We can get the target population with active TB case finding, and when we get 1 people with active TB, we check the contact. Yeah, like in COVID, we check all the household contact for TB. If there is symptoms or there is an active TB, we treat them. If there is no active TB, we in children under 5 years old, we give the TB tuberculosis therapy. But in children 5 years old or in the adult people with household contact, we must do the IGRA or tuberculosis skin testing first to make sure they are a latent TB. And if there is a latent TB with no sign of infection, we have to give the TPT or TB to a preventive treatment. So this is the algorithm for TB screening and TB preventive treatment. First, we must see the target population who will get benefit from the preventive therapy. First, HIV patient. Yeah. Now all the HIV patient must screen for TB. Yeah. If there is any symptom like current cough or fever or weight loss or night sweat, there is a symptom, we must investigate for active TB. If there is no active TB and there is no contraindication of preventive treatment, we do the preventive therapy in HIV patient. Yeah. And the second population that we will give the TB preventive treatment is the household contact with the index case with bacteriological positive. If the household contact is symptomatic, we must investigate the active TB. If there is no symptomatic, if there is under 5 years old children, we can give the preventive therapy. But in 5 years or above, they must get TST or IGRA first. If there's a positive, we can check the chest radiography. If there is a normal, we can give preventive treatment. If there is an ecthermal, we can investigate the active TB. And if there is active TB, we give the treatment. Yeah. And other risk group is people with immunocompromised condition, diabetes, chronic kidney disease, people with cancer or lymphoma, yeah? People with chemotherapy. We must check the IGRA or TST. If there is positive, but there is no sign of TB, the chest X-ray is clear, we can give the TB preventive therapy. And what we give for the TB preventive therapy, we have 5 regimen available. We can pick one of them. There is 6H or 6 months with isoniazid, or 3 months with isoniazid and rifampicin. It gives weekly, and 3 months with isoniazid and rifampicin daily, and 4 months rifampicin, or 1 month with isoniazid and rifampicin that give daily. Pregnant women also can have this preventive therapy if there's evidence of latent TB. Yeah. And for the HIV patient, usually we give them 6 months of isoniazid, because we don't need to consider the interaction with the ARV. And the last one is COVID with tuberculosis. We know that from the meta-analysis and systematic review, if there is a TB and COVID in one patient, the relative risk to worse clinical outcome is high. So when there is COVID and TB in one patient, the probability to give or to have the bad outcomes is quite high. So, and also we must consider that the anti-TB drugs will be interact with antiviral that we give for COVID. And I think this is all my talk. Hope you are not bored because I have a lot of time, a lot of speech. And for the take-home message, TB is still the #1 infectious disease killer in the world. And the diagnostic of TB is challenging. It ranges from simple to advanced intervention, but TB is treatable. And the therapy of TB needs multi-drug combination with long duration to prevent relapse. And also the latent TB need to be treated or to be give the TB preventive treatment to achieve the elimination in 2030. And thank you for all your attention. And I would like to have a discussion with you. Thank you.
Okay, thank you for the informative and interesting lecture from Dr. Nur Rahmi Ananda. All right, ladies and gentlemen, now we come to the questions and answer sessions. There will be 2 sessions and each session is for 3 questions. Don't forget to mention your name and your country where you come from. Any questions? Any questions? From India, I think there is from India, from Bosnia, Spain, Libya, Pakistan. Is there any questions? Is there any questions? I think Dr. Nur Rahmi already, presenting gorgeously, so everyone, well informed with your lecture, I think, Doctor. There's no questions. Okay. Okay. If there is no questions, I conclude first. There is no doubt that this pandemic has had a devastating impact on tuberculosis disease. As you can see in the graph before, the number of the death due to tuberculosis is decreasing every year, but suddenly it rising due to the pandemic. A part of that, many factors leading to tuberculosis, #1 infectious disease killer, such as challenging disease, challenging diagnosis, long-term therapy, and the resistance of drug. I think that is the inclusion of the Dr. Nur Rahmi sessions. I think that's enough. Maybe the master of ceremony would like to continue the session. Oh, there is questions, Dr. Nur Rahmi. If a breastfeeding woman has TBC, will the child get affected?
Okay, thank you for the questions. May I answer the questions now?
Yeah.
If the breastfeeding woman have TB, we know that the transmission of TB is airborne. So the transmission, the infant can be affected from when the mother is positive or active TB, but since the it's transmitted from the droplet or the air. So since the breastfeeding is very important for the baby, so we can advise the mother to do therapy and use the mask to prevent the risk of transmission to the baby. So the control of infection control is mask. They should give mask. But they should continue the breastfeeding. Dr. Fahad, I can't hear your voice.
Oh yeah, I'm sorry. So it's affected if is there's not affection to breastfeeding to the baby.
Sorry. Yeah, it's effective. It affected not because the breastfeeding, but the interaction. So to avoid that, a mother must have put mask on the face, and also the baby, because the quite close contact with the mother, the baby is also have to investigate for latent or the baby have a preventive therapy. The baby usually give the preventive therapy if there's no symptoms of TB disease.
Okay. Okay. Thank you, Dr. Nurrahmi. Is that clear enough for the one who questioning about the is that affected breastfeeding to the baby? Is there any questions? Oh yeah, it's from Ansa. Excuse me, I want to ask this. Can COVID and TB infect a person in the same time? And how to treat that patient? It's from Ansa.
Okay.
Can
Actually, we have some patients with tuberculosis and COVID co-infection. We treat the patients with with TB drug. We continue the TB drug, and also we give the therapy for the COVID. Yeah, like we give them antivirus. If there's a severe, we give them steroids. Yeah? But the important is to give the other support like oxygenation and also nutrition. Yeah. So although there is a risk for the worst outcome, but in our experience, the patients can discharge safe. Yeah. Yeah. We treat TB. The TB drug is we continue, and we give also the antivirus and treatment for COVID. But we must make sure that there's no interaction between drugs, yeah? And we monitor the condition day by day, and we give the supportive treatment, oxygenation, nutrition, and fluid. Yeah, I think the therapy or the monitoring is very important to treat the TB and COVID disease.
Okay, I think these questions correlation have a correlation to the next question, Dr. Nurrahmi from from France. If a person got TBC with COVID-19, which one must be cured first?
Okay. Okay. We know that TB is a chronic disease, and we know that COVID is like an acute. Yeah. So usually we treat both. We do not discontinue the TB treatment. The TB treatment is still, we give the patient, but we monitor closely for the worsening of the COVID sign. So we treat the COVID, we treat the TB, the therapy treatment is continued, and we also give the therapy for COVID and monitor the COVID, because usually COVID is like one period, like 2 weeks, like in 10 days or 2 weeks, if the patients have if the patient can can through the time, usually the COVID is is cured, yeah, and they can melanjutkan, they can continue the TB treatment.
Okay, thank you,
And
Dr. Tony.
yeah, and after TB and COVID, there is there is a risk for the worsen pulmonary function, yeah, because both of the disease will give the will make the fibrosis in lung. So the COVID can have the sequel, can give sequelae, can post-COVID, the patients can get fibrosis, and also from the TB, the patients can get fibrosis too. So we monitor the patients, we do the chest physiotherapy, and we do the therapy to increase the lung function in this patient.
Okay, I think that's enough, Dr. Nurhami. Is there any questions more? Okay, he said, thank you, doctor. It's Prince from France. Okay. Is there any questions more? I thought there is no participant from France. It's in here. It's written Libya, India, Bosnia, Spain, Pakistan. Is there any questions? Okay. I think that's enough. Dr. Dorami, thank you for all of your lecture and also your answer the questions. I think I have to give my sessions to the Master of Ceremony to continue these sessions. Thank you.
Thank you so much, guys, for your eagerness to learn and participate in today's session. And I also would like to thank Dr. Nanda for the material, and I would like to thank Dr. Fahad for being the moderator in today's session. It is such a valuable experience and such an amazing session. We would like to thank both Dr. Nanda and Dr. Fahad for their participation by giving certificate of participation. Maybe first we would like to share the screen of Dr. Fahad's certificate. Okay, we will take a short photo session, maybe for documentation division.
Okay, I will take a picture. 1, 2, 3. Okay, one more. 1, 2, 3. Smile.
Okay, thank you so much. Now we can share the screen for Dr. Nanda's certificate. Please, documentation division.
Okay, 1, 2, 3, smile. One more. 1, 2, 3. Okay, thank you.
Okay, thank you so much for both of our incredible doctor, Dr. Fahad and Dr. Nanda, for participating in today's session. All right, guys, today's session already come to a close, and I really want to thank all of you guys who have participated in the 5th day of International Tropical Medicine Summer School 2022. Now, before we close today's session, we would like to have a short photo session. So maybe you all can turn on your camera, use your virtual background. Let's go, guys. Let's go turn on our camera. It's just a short photo session. I think we love to look at old pictures. Maybe we can see it again later when we want to remember what we have today. Okay. I can see Najla. Oh, hello, Najla. How are you?
Hello, I'm good. How are you?
You're from Bosnia, right?
Yeah, from Bosnia.
Is it night or day in there?
It's early in the morning.
So you have a really great spirit. I really would like to thank you for your great spirit. I know it's sometimes hard to wake up in the morning. We would like to thank you so much for waking up.
Thank you.
You know,
Okay, anyone want to turn on their camera?
I prepared how to greeting in Bosnian.
Yes.
Okay, Nejla. Zdravo,
Zdravo.
dobro jutro.
Yeah, it's the morning here. Dobro jutro to you too.
Okay.
Thank you.
Because I already prepared. Okay.
Okay, maybe we can start the photo session now. For documentation division, you can take the picture.
I will take a picture. 1, 2, 3, smile, everyone. Okay, one more. 1, 2, 3, smile. Okay, thank you, everyone.
Okay, thank you so much for your participation again. I would like to thank you all again for today. And I really hope the material will give you a new insight and new experience. And don't forget, tomorrow we will have the second session of tutorial and skill lab. So you can access the tutorial mechanism video and the skill lab material on my class website. I'm Nisa Humaira, your Master of Ceremony for today. Thank you so much. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Doctor.
Thank you.